I'm Udho Thadani. I'm from University of Oklahoma Health Science Center, Oklahoma City. I'm emeritus professor, but still active cardiologist on duty at the VA Medical Center and University of Oklahoma, practicing clinical cardiology and doing a fair bit of research. And my topic of discussion today at the session at 11:15 is older and emerging concepts in the treatment of refractory angina. Refractory angina is a term which is utilized as no-option angina. Patients are on medical therapy and they've already had revascularization or are not candidates, so it's been considered no-option angina. Older treatment still is the same in that we give medications to prevent serious adverse outcomes like heart attacks, death, and that's really done with aspirin and statins, lifestyle modifications, controlling blood pressure. But there are a lot of patients who, despite all that, are continuing to have angina. They are already on a beta blocker, calcium channel blocker, or nitrates. And question is what to do with these patients. There are several things we can do. In England, I think they do a great thing. They've got a multidisciplinary approach. Patient is investigated, and they try new modalities, even in this country now. And what you do is you can try newer drugs. We got several new compounds like ronalazine, but again, the data on the double-blind studies is not there, but at least you can try that if other medications are not working, provided the patient is a candidate. Then if they don't respond to that, in Europe they are doing trimetazidine, which we don't have it here, which doesn't lower the heart or blood pressure, and ivabradine is another compound which is coming on the horizon in Europe. Again, the data is kind of soft. Now, there's a machine called EECP, which is enhanced external counterpulsation. You put the cuffs on the leg, the blood pressure is increased, and then it you have 35 sessions. It's expensive, but subjectively, registry data shows that it might be very effective in these patients. Again, no double-blind studies, but again, worth considering that. If that fails, then you can have neuromodulation, which is called spinal cord stimulation. It's an invasive procedure, but again, in patients who are refractory, it is worth a consideration. Chelation therapy has played a role, but the data is again plus minus. And again, the same can be said for the arginine replacement therapy. Now, what is exciting is a lot of these no-option angina in the past are now being considered for possible opening of the chronic total occlusions in the coronary artery. So what they do is, if you have ischemia or patients getting chest pain, they can do that with a good success rate, about 70%, and in the newer technologies or the methods, it could be up to 80%. So it's worth a consideration. Again, unfortunately, we don't have sham control studies to prove or disprove, but it's worth a consideration. And recently, there is a new technique in which they put a stent in the coronary sinus to partially occlude the drainage of the coronary sinus. It increases retrograde perfusion. So again, that's a hope. So I think in a nutshell, it should be a multidisciplinary approach, and patients who are still stable, a lot of patients also should be encouraged to exercise, despite the fact they've got a refractory angina, because that can improve their symptoms. And finally, unfortunately, there are going to be a group of patients who may end up having a transplant if they are candidates. And if that doesn't work and patient is really miserable and suffering, you might have to consider hospice in those patients. But again, hope is on the horizon. Prognosis is not as bad as one thought, so I think one should try the best for these patients for the management. I think it's important in the sense because it's a multidisciplinary in the sense although it's focused on cardiology, but you're going from prevention to treatment to valvular heart disease. So I think if one can cover a large area and hear from the experts, 15 talks are 15 minutes, but you are covering a large number of topics. So I think I attend sessions which I have not, very often I go to, like I might go to prevention more because I know about other topics. So I think it's an important venue, obviously, how much one can do as a student when you're already in practice. So I think also by encouraging the young students, young people to come and show their data, not only in posters, but also include some presentation is very useful, I think. for the purpose. Plus, it's international. So I think we are encouraging colleagues from abroad to show, and some of them are doing very exciting stuff. And so I think it's nice to know. Plus, it's a smaller meeting. So when you go to the Harvard College, it's a huge meeting, 35,000. You can't go from one room to another. Here, at least, if you want to move from one section to another, it's easier, walkable distance. So that's the advantage.